Okay, so we'll go ahead and get started now. Welcome to the third part of Mastering the Nuances of InBrace, a deep look into case studies. So just some background. So my name is Robert Lee. I'm the InBrace co-inventor, the head of clinical affairs, and the senior clinical advisor, and I'll be going over today's webinar. And our team is very committed to orthodontic education. We have a team of almost 10 orthodontists now, and you'll see that we're going to be releasing a lot more content in the near future. In our Facebook in group, we're starting to post weekly with our What's the Future Wednesdays. We'll be coming out with more clinical guides as well as more courses on InBrace learning, which are self-guided virtual courses. So we're making some updates to them. So you'll see that we will have an update to the fundamentals of InBrace mini residency, particularly with the Smile Design module coming out in the near future. And we also will be coming out with the Smile Design reference guide that we announced last week, which is a reference to the Smile Design module. So a lot of people had told me that while the videos that we're creating are really great, it's hard to remember all of the everything that was gone over in the videos, and to have to go back into videos to find the overcorrections that you're looking for was a little bit arduous. So then we designed this reference guide that should be released digitally in the near future, and then will be also released in print and be delivered to all of your offices. And it was developed in conjunction with Dr. Scott Schwartz, who's one of our top providers. So this is the third part. So we designed this webinar series to kind of set the foundation for everybody, where the first webinar was to go over the general clinical approach. The second webinar was to go over the Smile Design portion of things. And then this last webinar, now that we've gone over the clinical approach, Smile Design, kind of review the general systems, we're going to go into a look into some case studies. This webinar series, again, was designed to kind of set the foundation for everything going on to the future. So, there will be many more webinars in the future, and then we'll be able to cover more complex topics, more advanced topics, more complex cases, topics such as finishing, troubleshooting, class 2 correction, etc. So we named this series the Mastering the Nuances of InBrace because, I think of orthodontic treatment that there's just nuances in general. Like most of orthodontics is like 90% the same, but that last 10% is just kind of different between each modality. So we've gone over this in the last two webinars, but just, traditional braces and aligners both have a lot of nuances to them, where there's a lot of education that you need to make that modality predictable and efficient. So with InBrace, it's the same thing, where InBrace is a new category of treatment. We have to create new systems for your diagnosis and treatment planning, your clinical decision-making, and your hands-on delivery. I'd say these are the three essential areas, no matter what type of treatment, that has to go well for the treatment to go predictably and efficiently. So the first webinar, we went over Smile Design. The second, or clinical approach. Second webinar, we went over Smile Design. And then today, we're going to also touch on the clinical technique. So just a quick review of what we've already gone over. We talked about this systematic approach where you go over the patient-specific ideal setup, you add some overcorrection, and then you add the clinical approach to it. And we went over these 5 general steps, which is also in the reference guide. And then generally with your overcorrection, you're going to evaluate your desired tooth movement, the biomechanics required for it. You're going to determine whether the potential side effects are favorable or unfavorable. And then you add an overcorrection as needed to increase the force level and or counteract any unfavorable side effects. And I always just like to remind people that overcorrection in the proper direction is the most important thing. That the exact amount, whether it's you added 3 degrees or 5 degrees or 7 degrees, or whether you added you overcorrected over by a millimeter or a millimeter and a half, as long as you're overcorrecting in the right direction, that's the most important thing. And any minor details after that, if didn't detail out perfectly, you can be taken care of very easily in digital enhancement. And with DE Smile Design, we generally recommend kind of a less is more approach, and to treat it very similarly to how you're approaching traditional braces. And so we went over these general key nuances within the Smile Design. And the ones that I really like to always make sure that people are aware of is, again, that upper central incisor rotation tip side effect, making sure that you're reading whether that's going to be unfavorable or favorable, and then adding overcorrection or just leaving the overcorrection we've added in for you. And also the additional virtual power chain. I think those are the 2 main nuances of the Smile Design process. So in the initial Smile Design, generally making sure that you're not going to get a space opening between your upper 2 to 2, so your upper front teeth. And then in your DE Smile Design, you should be doing it for all your contact points, just to make sure there's no spaces occurring during your finishing. And that's very similar to, I would say, you're adding a power chain at the end of your treatment to make sure all your contacts are closed at the end of treatment. With traditional braces, you're essentially doing the same thing here now with the DE smile design. So we also went over the clinical approach. And in the clinical approach, we broke things down into stage 1, stage 2, and digital enhancement, where stage 1 is your initial leveling aligning. It's pretty similar to your 014, 016 night tie wire. Stage 2 is your working phase, where you're running your inner arch mechanics. So you're running your class 2, class 3 vertical elastics. And then digital enhancement, if needed, is your finishing. And then we broke down each stage into component goals. That way you know exactly which appointment what you should be doing at each appointment. So in your stage 1, you're trying to get all the brackets in the right spot, what we call the planned bracket position, perform your IPR, and then let the Smartwire express until you finish your initial leveling aligning. Then you can go to stage 2. You can allow your Smartwire 2 and or 3 express. We kind of went over when do you use Smartwire 2 and when do you use Smartwire 3. Most of the time you're just using Smartwire 2. You're going to resolve, nearly resolve, or accept your inner arch discrepancies. That's the most important one in stage 2. That way, when you get to your finishing, there's not much, your inner arch mechanics are complete. And then you should be removing or reducing your bitropos as you no longer need them as much as your case starts to progress. And then finally, with digital enhancement, if it's needed, you should proactively adjust your DE smile design to support your final detailing. That's probably the most important thing, is to set up your DE smile design properly, which we discussed a lot in a lot of detail last week. And then you simply just perform any clinical adjustments and allowing your Smartwire 2 to express. So it's usually fairly straightforward to finish after the DE smile design is planned properly, and resolve any remaining in-charge discrepancies, which shouldn't be very much if you've done stage 2 properly, and then just settling the occlusion. Okay, and then today I'm going to just very quickly touch on the clinical technique side of things, just because we've discussed that that's an important topic. Most of the clinical technique is already taught to all of our providers by their TISs. So I'm only going to spend 3 to 5 minutes on this section, and then we're going to go into the case studies. So we do have a required materials guide. Everything that I'm going to reference going forward is based on the required materials. We have vetted a lot of different materials over the years. We did extensively look into different adhesives, etches. We've tried many different protocols in our bonding, which we call the fitting. So we know that these ones are tried and true. We know there's a lot of research behind this because a lot of them are Reliance products. And then Reliance has done a lot of research on their products. So we know that if you follow our recommended guidelines plus use the required materials, that you're going to have a very predictable hands-on delivery of InBrace. A lot of what we're going to go over too is just kind of what we hear from our TISs. They're in the field talking to hundreds and hundreds of providers, and we know these are the issues that we commonly hear about and see. So the first one actually is a very straightforward one, just a reminder that you're working on the back of the teeth, you're working on the lingual, so you really do need good lighting. I've always been surprised when TISs come back and tell me, there wasn't just proper lighting, and it was really hard to work because there's no lights. So with the fitting appointment, we do break it down into multiple steps. We have the tray preparation, teeth preparation, your bonding, and your post-bonding steps. So with the tray preparation, I'm just going to go over kind of the nuances of each step. So with the tray preparation, we do recommend using the adhesive fill guide. We did design it so that it standardizes your fittings between all of your assistants, because now you have an exact amount of composite that should be placed for each bracket. Traditionally, we did teach using Light Bond, but Go-To is another product by Reliance. And we found that it really does help to use Go-To because it fluoresces under the black light when you're doing your composite removal. And then normally we prepare our IDB trays on the same day as the fitting appointment. So we don't do it right before the appointment. We just do it all in the morning, usually we put in the retainer case that's provided. We put the retainer case back in the patient kit, put the patient kit back in the cabinet so that no light gets to it. We do recommend for the teeth preparation step both a pumice and a micro etching step. When you're working behind the teeth, there's just it's just easier to I would say have on you really want to make sure to have good bond strength. You don't want to be replacing these brackets or having to repair as many brackets. So we do recommend both the pumicing and the micro etching step because both help with the bond strength. Another thing that we often see is over etching. Paul Gange from Reliance also talks about this a lot. So we usually recommend etch half the arch at a time, just so you're not over etching, and to make sure you're rinsing enough. So it should be 5 seconds per tooth with liquid etch and 10 seconds per tooth with the gel etch. We also recommend using a dry air source. And then when you're doing your light curing step, should be 3 5-second light cure cycles, meaning you light cure when you're holding the IDB tray, you light cure when you're no longer holding the IDB tray, and then you light cure once you take the IDB tray off. About 50% of the intensity is lost when you cure through the IDB tray from our testing. Also, after you finish your fitting, you should be checking for voids. So after all the IDB trays are off, you should be checking and adding any flowable composite into the void spaces. We really like using this blue etch tip. There's many ways you can do it. You can apply it to an Explorer, you can apply it to a micro brush to kind of brush it in. But the edge tip is very, very thin. So it gives a lot more control. You just have to push a lot harder, but it's very controlled when it comes out. Flash removal is another step that I think is commonly missed. So with the black light, it really makes it easy to remove any of your excess flash. And then always making sure your contacts are open with floss. If you do have a contact that's that has composite in it, the serrated IPR strip, this Contact Easy one, usually works really well. With the black light too, something that I thought was interesting, we have no financial interest in this, is the clip-on black light by Ember Light Therapy. So that works really well. Or you can just get the ones from Amazon. For all the assistants that we're training, I always make sure that after they put the wires in the first few times that they're putting it in properly. What I notice a lot of times is you'll see some excess space here between the neck and the bracket. And it's because they're not getting the bracket, the locket fully engaged. So, there's the shoulders of the brackets. You have to make sure that the shoulders of the locket are underneath the occlusal tabs of the bracket. So sometimes it's both of them that are not pushed underneath. Sometimes it's just one of them. So when you have these situations, you should be pushing with the engager to push this into place. If any of your assistants are having trouble getting the Smartwire in, first thing I just tell all my assistants, go grab some free spray, make it softer, and then usually you can get it in with the free spray. When they're ready to disengage, we do provide the engager instrument. With disengagement, I recommend the angle tip for posterior brackets and the straight tip for the anterior brackets. We do have a great video on this on the knowledge base. If you're having trouble though with disengaging, especially with the heavy force brackets that we initially had, Dr. Scott Schwartz and Allure Orthodontics created the Smartwire Plier. So this works really well to get the Smartwire out. Just some general tips with it are to make sure you're adjusting your chair position so you have the proper angle. Sometimes when there's plaque buildup, a tip is you can squeeze up and down just vertically 3 times. That way it kind of loosens up and breaks up any of the debris. So just like this, just squeeze up and down 3 times, and then you can squeeze it out. So again, it's just trying to break apart any debris that might have got stuck in the locking spring. So when you do have a debonded bracket, say during the rebonding procedure, you can either take the Smartwire plier or a Hue-free lingual Weingart, which is a very thin tip. And then it's very easy just to squeeze and get the bracket off. And then when you're ready to section the IDB tray, you can what works best is either like a box cutter or this rubber cutter. Because if you use like a X-Acto knife or like a scalpel, it's gonna bend. So you need something like a lot heavier duty that works really well. So this is a clinical pearl by Dr. Scott Schwartz. My assistants really like the rubber cutter. You can get it on Amazon. It's very controlled and it cuts really nicely and smoothly. So that works, I would say, really, really well. When you're ready to insert the bracket into a tray to rebond, you could use like tweezers or you could use your Weingart. But Dr. Tong, our main inventor, he came up with this technique where you just take the back of a microbrush, add a little tiny piece of adhesive to it to make it sticky, and then you could actually just put the bracket in without having to hit the walls, the mesial distal walls with the tweezers. So this works really well in terms of loading the IDB tray. And then a final pearl by Dr. Hap Doherty is when you're trying to engage a posterior IDB tray that's like sectioned, sometimes it's hard to get your fingers to hold that far back. So you can just stick the Explorer into the top of the occlusal tray, and then that will act as your handle. So that works really nicely too. And it's essentially everything I've just gone over. We have great technique videos available for them. And then your CIS can also show you any of these techniques as well. So, and then if there are any other techniques that, you're struggling with or you need a video for, just let your TIS know. They can relay it to us, and we're constantly and actively building out this library of techniques. Okay, so now we're going to go into the actual case studies, the meat of this presentation. And so the purpose of these 4 case studies is just to demonstrate how to predictably and efficiently treat straightforward cases with InBrace, so like 6 to 12, 12 to 18 month case types. Again, my goal with this 3-part webinar series was to set the foundation. And I just thought when you're setting the foundation, you need to first be able to create forward case types. If you can create all the straightforward case types, then we can build on that very easily and just add, auxiliaries or add just different topics to go over more advanced cases. So again, we're trying to reinforce these systems and nuances that we discussed in the past 2 webinars. I'm going to be showing all the common, a lot of the common pitfalls. So I personally experienced some of these ones, and as well as we see these commonly in the clinical review process. And then again, future webinars are going to show more of the advanced cases. So, so in the first case, the areas that we're going to focus on and kind of watch and throughout the progression of this case is first in the smile design, like how does an improperly designed smile design, how can it cause unintended tooth movements that can delay treatment? From the clinical approach, main goal is how are we progressing through the standard treatment sequence that we've been discussing? How can you settle a case with the retainers? And then from a clinical technique perspective, I'm going to go over how to deal with the debonded brackets that happen throughout treatment. Okay, so this is a super straightforward case. This is a case that, should take less than 9 months based on how you do your coding for straightforward cases. But this is a very, very straightforward case that, I have seen providers, I would say, have go wrong when they don't know what to watch out for. So, we're going to go through this InBrace smile design systematic approach for the 5-step process for how do you review the smile design. Okay, so when you look at this case, we're going to turn on the transparency. We're going to do the vertical. We're going to turn on the grid. I'm going to measure the initial overbite. When I count the squares, it's about 2-3 millimeters. And then the initial is also about 2 mil. The ideal is also about 2 millimeters. So then you look at the crowding and spacing, and we know that in this case it's pretty negligible. So because of that, we know the resulting overbite. We don't really have to overcorrect the vertical because it's about ideal to start with. When you look at the AP and the transverse, also this is a straightforward case. They're pretty much ideal to start with. So, your first 3 steps you can do in like 30 seconds where, okay, no overcorrection, nothing really is needed. It's all pretty good. Arch length discrepancy is pretty straightforward. But where we're looking here now is you can see that upper left 4 and that upper right 4. You can see that torque being applied to it. That is going to cause a vertical change. And we kind of discussed that torque causes vertical changes in the last webinar. But you can see actually when you look at the buccal view, however, the buccal view, you don't see any change in that vertical height. So we're going to be highlighting and looking at what that affected that torque change is. The upper ones, in this case, there was some distal out rotation. The lower, there's not too much going on. But yeah, when you look at this upper ones, you see the upper ones also require some mesial root tip. And then the upper ones also have a distal out rotation. So actually that's a favorable movement with the rotation tip side effects. So because it's favorable, actually, again, it's very straightforward. No overcorrection is needed in this case because, again, that distal out rotation is going to cause that mesial root tip. So where the distal out rotation may cause more concern, though, is with space opening. So when you have a distal out rotation in your initial case, it's going to create a wider IP loop to begin with. And then when you engage that wider IP loop into the malocclusion, it sometimes will cause an open coil spring effect that may open a space or may make the contacts a little bit lighter. So in this case, what I would have said or would have changed is I would have added just a little bit of additional virtual power chain between the upper ones. This is a minor rotation in this case, so 0.3 millimeters should be sufficient. Now in this case, this is what I should have done. At the time when we were doing this case, we were still learning a lot of these things. So what I would expect may happen is, space may be forming because we didn't add the additional virtual power chain here. The other area that I was commenting on was the torque expression of that upper premolar. So with the upper premolars, the palatal root torque will end up creating almost kind of what we call a step down bend. So if you kind of look at the malocclusion here, the brackets start level with each other. And then in the small design, because of the torque, it will actually cause a vertical change of where the bracket ends up. And remember, the wire is going to be designed where the bracket ends up in the small design. So based on this position, you can see this vertical difference now between the brackets. The wire is going to be engaged back in the malocclusion, and it's going to want to cause an extrusion of this upper premolar. So what commonly you'll do instead is either you have to add a vertical overcorrection, or what works better in general is, what actually this tooth needed was a step out as well. So if you just stepped it out, you remove the palatal root torque. When you step out a tooth, it's going to naturally cause some of the palatal cusp to drop as well when you step it out, because it's not going to translate perfectly. And then you'll essentially get the same effect. So what I would have done here again, I would have just asked the small designer, remove the palatal root torque and then step it out instead. Okay, so that's the small design. Again, those were the two main nuances, I would say, of what this case missed when we were doing the initial small design. But then looking at the case, first you start with always looking at your treatment instructions. In this case, there's no bracket repositions or blocked out teeth. You have mild crowding. There are a couple of brackets that have some interferences, so you may need to add some bite turbos. So we started this case off with the fitting appointment where we did the upper and lower arches are fitted, which are again our term for bonding. And we engaged the upper and lower Smartwire 1. During the fitting process, the lower right one bracket well was torn. So we realized that it wasn't going to be usable. So anytime you have a well torn, because you want your IDV trays, you always need to have your IDV trays in the case that your brackets ever debond. That way you can reuse the trays to rebond it back on. You should always just then item request for that tray. So again, if you have a tray well that tears during your fitting process or during your rebonding process, immediately what you should do is just item request for that replacement part. So going on to the next appointment, the first appointment back, appointment 2, all the brackets started in the planned bracket position to begin with, just based on the initial fittings. That actually technically already completed your first goal. Some IPR was prescribed, only 0.2 millimeters, so we can take care of that in this appointment. And you can already see by this appointment, the leveling and aligning essentially has already expressed. So, all the brackets are in the planned bracket position. It's been 2 months that you've been letting the Smartwire 1 express, and the IPR is going to be performed in this appointment. So that means all the stage 1 goals have been completed, and we can engage upper and lower Smartwire 2. So again, very straightforward on how do you know when you go from Smartwire 1 to Smartwire 2. So we'll say that this patient came back for a care and repair visit. That's what we call our SOS or emergency visits. A couple weeks later, and then the upper right 5 debonded. So what options do you have when the patient comes back in during your busy schedule with a debonded bracket? So one option is you can just leave it off, section the Smartwire if it's bothering the patient. A lot of times it's actually not bothering the patient if it's in the middle of the Smartwire. But if you are going to section the Smartwire because you only have a few minutes to spare, usually we use a straight cutter because it gives you a little bit more control. You just cut it straight at the shoulder area of the IP loop. And then you hold the IP loop with one instrument and you cut with the other instrument just so that it doesn't go flying off. So you're just holding again with a Matha or a line guard and just section the Smartwire. And then immediately again, after you section anything or you have something broken, just item request for the replacement part. And then usually it'll come within 2 weeks. Your other option is to rebond your upper right 5. So this is kind of, again, the steps that we just went over with the clinical technique section where, use your lingual line guard or Smartwire plier to remove the debonded bracket, use your rubber cutter or your box cutter to section the IDV tray, load the IDV tray with you can use that microbrush clinical pearl. And then, this is a posterior to the upper right 5. You may end up using the Explorer to help you see the tray. And then again, my general recommendation is, item request always has the backup parts that you need. I also recommend that whenever you're seeing an InBrace patient, commonly what a lot of people do with aligners as well, is you should just have the portal open so you can check your small design, make sure that the teeth are moving how you planned. And then also if, something does break or, Smartwire is broken, you can always item request for a part immediately if needed. So with the item request feature, you can request for replacement Smartwires or replacement IDV trays. Okay, so then now the patient comes back for their 3rd visit. And so, at this point, Smartwire 2 has been engaged for about 2 months. We don't really need any inner arch discrepancies. Again, these are the stage 2 goals. And there wasn't bite turbos actually to begin with. So actually the stage 2 goals essentially are complete. Sometimes we do let the Smartwire 2, 3 go to 4 months, but if you are going to go to digital enhancement, there is also the period of time it's going to express while it's in digital enhancement. So, honestly, at this point, the patient was pretty happy. There wasn't really much left that he wanted to do. And then when you're assessing your detailing, it's the same as if you know, if you're assessing your detailing for traditional braces. So you know, some of the things that I was looking at were, you know, the upper fours that did end up over extruding. So if you look at, like, again, the leveling between the upper threes and the upper fours, you can see the upper four is over extruded, as I would have expected now looking back at it, something that I didn't realize when I was doing the initial smile design. One of the other things that did happen, you know, was there was a space forming, a very slight space, but, you know, when I'm checking for my final, from finishing, you know, I'm checking, should I check all the contacts, and then it's okay, there's a slight open, or maybe a light contact between the upper ones, that additional virtual power chain that I mentioned at the beginning would have helped resolve. And then there's just minor detailing things that we know we could improve. Say, for example, like the lower left 1 and 2 area could improve. So, you know, we decided to do a digital enhancement for this patient. And in this page, so the first step with your digital enhancement, again, is make sure you do a good DE scan. So if you have, say, like SoftFlow or Firmit or Telio, or you didn't dry the brackets, we can't see the brackets, and you're not going to get a good Smartwire that will help with your finishing. We might even have to ask for you to reposition a bracket. That's why I always let all my assistants know, okay, we're doing a DE, make sure you're going to do a good intraoral scan, make sure you can see every bracket very clearly in the scan. And so with DE, first step is just do that proactive DE smile design, where quite often, you know, your first 5 steps, and the 5 steps, you know, the first 4 you can generally skip because it should have already been resolved. And actually, even in this case, in the beginning, the first 4 steps were essentially skipped. So main thing we're looking at here is just kind of the minor detailing you're trying to do. You're trying to leave as many teeth still as you can. So really the only movements we added here is we extruded upper 3 to 3 by a millimeter. This is partially due to the over extrusion of the upper 4s. So we're trying to gain a little bit more overbite back. We have some minor detailing. It's kind of essentially how you would do your detail bends. So, you know, I'm adding some mesial rotations to upper right 2, some general rotations. So it's almost exactly like what I would do in my, again, detail bonding. The one area that, you know, you can also check with your DE is your bracket position and your Smartwire activation. You know, in this case, your bracket position, everything started in the planned bracket position is exactly how we designed it. So most likely, there is not going to be any issues with bracket positioning, but you should double check that. With the Smartwire activation, one thing that, you know, I added that probably was unnecessary was rotation on the upper 6s. So I've shown this image before, or an image very similar to this, where, you know, if you have an increase in that inner bracket distance between your upper 5 and 6. So in this case here, you can see in that the video, you know, the upper 6 is rotating mesial in, distal out, and it's causing that increase in inner bracket distance. If you don't add the additional virtual power chain to bring it back down to about the 5 millimeters that it initially started, so you'd have to add about a millimeter or more of additional virtual power chain, you may get that, again, that open coil spring effect, potentially causing a space opening. So again, this is something, you know, we weren't aware of when I was doing this case. We learned about it actually kind of through this case and maybe a few of my other cases. And so, you know, this is something we're gonna be highlighting throughout this case. So then you look at your DE instructions. The instructions are very straightforward, no actions needed in this case. So, you know, with finishing with DE, the first, you generally would just go straight to DE Smartwire 2. You don't need to go to the Smartwire 1, because you can engage the DE Smartwire 2 easily. There's only minor movements happening here. Because of the upper 4s had overshooted, I'm now trying to extrude your upper 3 to 3. We did start some nighttime vertical elastics. I've gone over in the past 2 webinars. My preference for it is bonding buttons on the lower 2s and then having them run it from the IP loop to the upper 1s. This is very discrete that patients prefer. So I'm just trying to support my vertical movement. So with extrusive movements, usually I recommend trying to back that up with elastics when possible, even if it's just nighttime and with light elastics, it usually, I would say, helps support it and makes it more predictable. So when the patient comes back next month, or the next visit, about a month and a half, 2 months later, usually I'm thinking, okay, this is probably going to be a debond check when there's just minor movements. You know, if you have a lot of root tip movements, you might let it go for another appointment. But in this case, there was all very mild movement. So I'm expecting that most likely this patient will either be ready for debond or may need another digital enhancement for any final detailing if I didn't do quite enough in my detail bends in my Smartwire design. So when this patient came back, we actually did notice, a space is forming. Actually, you can see here that the upper threes and the upper fours have improved. So before, again, the upper fours were more extruded, but within that, month and a half plus the elastics, the upper threes, 3 to 3 kind of did extrude. The overbite did kind of re-improve because the overbite actually opened up too much because of the upper fours extruding. We did also, again, notice that a space did form between that upper left 5 and 6, kind of as we expected, that we would now expect knowing what we know about the smile design. So at this point, instead of, there's 2 options you can take at this point. You can either do another digital enhancement to close the spaces, or you can close it. You could wait and see if it's going to close, since sometimes when the wire is still expressing, it'll actually complete the rotation and finish closing the space. Or you could just close it with some active retainer. So, this patient, when we presented the options and kind of the timing that goes with each one, if you did a digital enhancement, you're looking at another few month turnaround time of letting, designing the wires and then letting the wires express. He said, for a space this small, it doesn't really make sense to spend that much time on it if you can close it a lot faster. And then I wanted to add a little bit more overbite still. And then he was starting to bite on the brackets, the upper brackets. So we debonded the upper, and then we just delivered 2 active retainers to close the upper spaces and run some vertical elastics. So here's the active retainer where we added some cutouts to the upper 2, so you can run some anterior vertical elastics at nighttime. And then there was some space closing built into that upper left 5 and 6 area. So just 2 active retainers. Also added a fixed retainer to hold the upper 2 to 2 in place, because he was just wearing the active retainers at nighttime. And so by the next visit, when the patient came back about a month later, the spaces have all closed now on the upper. We took off the lower. And so it took about 10 months, this case, about 7 appointments. This case probably could have been treated a lot faster if, again, we didn't make some of the missteps. So if I hadn't, over extruded the upper fours because of the torque side effect that I wasn't watching for, if I didn't get that space from the upper ones, you could have just done the active retainer part of things. I would say prior to digital enhancement, the digital enhancement would have been unnecessary. Could have finished this case in 6 months probably. And then even here, the active retainers only were necessary and only kind of delayed things a little bit because of a rotation that I built in that wasn't actually, I would say, necessary, or because I didn't add in the additional virtual power chain. So you had 2 options to kind of resolve that area. Okay, so kind of a general recap of this first case. The smile design, adding unnecessary movements may cause unfavorable side effects. So you should be removing any unnecessary movements. Less is more with the smile design. And then again, making sure to add the additional virtual power chain when applicable to prevent spaces from forming. With the clinical approach, again, this is a straightforward case to just kind of highlight how to do the standard treatment sequence. And then, the use of settling on active retainers, just 1 or 2 active retainers to help finish cases can, really expedite your treatment. And then again, with the clinical technique, item request for any replacement parts. Okay, so for the second case, again, with the smile design, we're going to systematically approach how to do the smile design. You're going to see again how an improperly designed DE smile design, may create spaces that is going to delay your finishing and treatment. We're going to go again through the standard treatment sequence, discuss how do you establish a proper overbite when there's interference with your upper anterior brackets. This will happen with some of your cases, and we're going to just discuss some general topics like single versus dual arch fittings, 5 to 5 or 6 to 6 or 7 to 7, as well as how to deal again with the debonded bracket. So again, another very simple case. This is a case that treat 6-9 months normally. Main concern was his gap between the upper front teeth. And so when looking at this smile design, going through this systematically, you see he has an open bite tendency. The amount of crowding spacing is fairly negligible in this case. So overcorrecting to about a 3 millimeter overbite by extruding both upper 2 to 2 and lower 2 to 2 by 0.5 millimeter past the ideal would help with the overbite correction. There is a class 3 tendency in this case, so I am planning on running class 3 elastics to make sure I have a sufficient overjet. So because I'm going to plan for, I personally do IPR quite often from lower 4 to 4. I'm going to do the class 3 elastics from the lower 4s since I'm trying to retract lower 3 to 3. So because I'm running class 3 elastics, especially when I'm going to run them early, I'm going to add some distal crown tip to the upper 6s. That's the most common one you'll add with like class 3 elastics. And then I don't want any extrusion on the lower fours because he has an open bite tendency. So I'm going to add some intrusion overcorrection to the lower fours. Transverse is normal in this case. With the arch length discrepancy, as I mentioned, I'm going to add some IPR. There is a slight bolt discrepancy with undersized upper laterals. And then with the diastema closure, it's a pretty small one. So if you remember, we said tip can be refined with 369. 1 millimeter diastema closure equals about 3 degrees of tip side effect per tooth. So we can add about 3 degrees of mesial root tip overcorrection to both the upper ones. And again, making sure that you have the proper vertical. So it's where the mesial incisor extrudes past the ideal and the distal incisor edge stays stable. So again, place the distal, so the 1-2 discrepancy between each other at the ideal location. Because there's going to be a little bit of torque loss as well, you can add some torque overcorrection. Also, this will help with establishing proper overjet. And then with detailing, when you're looking again at the tooth movements that are happening, the bite starts pretty solid in the back. So I would just say you shouldn't probably program in very much movement on your back teeth. You'll add in any ideal adjustments. You look at the pano. In this case, there's not any tooth that requires significant root movements. So you don't need to add any overcorrection there. There is no rotations on your upper centrals, which makes it very simple. So you don't have to worry about the upper central incisor rotation tip side effect, and you don't have to worry about adding additional virtual power chain for those upper ones. So looking at the treatment instructions, there's all the brackets again start in the planned bracket position. In this case, we started with the lower fitting. So we did so, and we made sure to do some of the IPR because what I didn't want happening was after you do the lower fitting, there is some mild crowding for the teeth to come forward and him to end up in more of an edge to edge or even a crossbite. If you had fitted the upper first, what I would be concerned about is, with the space closure, you may also end up with a premature anterior interference as the upper incisors come back. So that's why I chose going with the lower arch in this case and just making sure to do sufficient IPR so that there's no flaring of those lower incisors. So between 1 arch and 2 arch fittings, our general recommendation is just to do 1 arch. You see that I'll show cases with both, and it's because we're testing both paths with patients and seeing how they responded, as well as how our staff responded. And 1 arch fittings is just generally more comfortable. It makes I would say, easing the patient into treatment a lot more easily. And then it's also just easier on your staff. I would say the 90-minute 2 arch fitting appointment was quite long, especially when sometimes you have to do some IPR, you have to do some front bite turbos. It adds a lot to the appointment. So two 60-minute 1 arch fitting appointments rather than a 90 arch 2 arch fitting and then a 30-minute adjustment. This was a little bit easier for our staff as well as for our patients. In most cases, lower arch is fitted first. Generally, the lower arch has more crowding, requires more time than the upper anyway. So I always let the patients know, don't worry. It's not like the lower is going to be ahead of the upper. Actually, the lower generally just needs more time than the upper, just because we have to get all the brackets on in the right spot. Quite often, it's beneficial for your deep bite cases. So I always look at the lingual view when I'm deciding which teeth to fit, because a lot of times when you do the upper, you're going to be biting on the brackets. If you're biting on the brackets, you bite turbos, which sometimes can compromise the indirect bonding process on the lower arch. So I'd say 90% of the time, lower arch fitting first. Once in a while, though, if you have an edge-to-edge bite or certain situations where it makes sense to start with the upper or the patient's demanding to start with the upper, that's totally fine. But particularly, I would say you're in your edge-to-edge bite situations where if you were to go with the lower first, you're going to go into a cross bite. That's when you would go and start with the upper fitting, especially when there's no occlusal interferences as well. So again, we started with the lower here. In the next appointment, a patient came back about a month later to do the upper fitting. Usually I tell patients, you can come back somewhere between 4 to 8 weeks later. A lot of times my appointment intervals are roughly about 6 or generally about 8 weeks, about 2 months. So about every other month. But some patients with the fitting, they're very eager to get started. So if they're really eager to get started, then I told them, earliest I'll bring you back is about a month. That way you're pretty comfortable. You've gotten past that 2-week break-in period with the lower. So we put the upper on, we finished the remaining lower IPR. Because the lower teeth have come forward a little bit, the bite turbos ended up not being necessary. And then we also started the light class 3 elastics, to help make sure that I have proper overjet after the upper spaces close. So again, if you're going to run light elastics in Smartwire 1, if you're going to run elastics in Smartwire 1, make sure you're running light elastics. I do see all the time in clinical review people overpowering the Smartwire with very heavy elastics and causing extrusive or a lot of side effects that were unintended. So again, with AP correction, Smartwire 1 light, Smartwire 2 medium, Smartwire 3 heavy. So most of the time you're going to be using light and medium elastics. Okay, so patient came back 2 weeks later with a care and repair visit. Again, how do you deal with this? you essentially have your two options, right? You either leave the bracket off or you rebond the bracket. So we just went over this. One pearl when you're trying to do your rebonding with your sectioned IDB tray is you don't have to remove all of the entire wire. You can, but it's unnecessary. The wire is very flexible and you can actually even hook it onto your contralateral arch. So, here, we take out usually about 2 adjacent brackets on each side, and you can just bend it and hook it like one of the IP loops onto onto another IP loop as shown in this image. Again, you're just trying to create space so that IDB tray can sit. Okay, so at this point, what I'm looking at when a patient comes back for appointment 3, so first appointment was lower fitting, second appointment was upper fitting, and then when they come back for really their first check-in visit, all the brackets start in their planned bracket position. So I'm checking, okay, is the alignment proper? Do all the brackets look in the right spot? So goal 1 essentially is already achieved to begin with. All the IPR I'd already performed. I was making sure to do that early because I don't want to go into a crossbite. And so all the leveling and aligning is essentially done. So we're done with stage 1 at this point. And so we can engage upper and lower Smartwire 2. Because we're going to upper and lower Smartwire 2 and I'm still running my elastics, you can actually switch to medium strength elastics at this point. When I'm looking at my midlines, I can see midlines a little bit off. Could benefit from more class 3 elastics on the right side. The left side doesn't really need class 3 elastics at this point. So just to kind of maintain, I did nighttime elastics on the left side and switched to full-time on the right side to help with the midline correction. And so when the patient comes back, the inner arch correction is nearly complete. So, at this point here, essentially, if you had a more severe class 3 or you had a severe class 2 case that needs more elastics, essentially what you'd be doing at this point in stage 2 is you'd let them go, keep running your elastics, keep adjusting your elastic patterns until your inner arch correction is done. So whether you have a very simple class 3 case like this, or you had a 2-3 millimeter class 3 case, or even like a carry in motion appliance case, or using TADs, what you'd be doing is no different. The only difference is you might add a few appointments so that a little more of the AP correction could be completed. So at this point, we check the inner arch correction. It's mostly complete. Midlines are mostly on. So we told him continue the same elastics, and there are some final detailing movements, that we could potentially do for him. Honestly though, at this point, we probably could have finished him. He does need a little bit more overbite. That was the main thing I was trying to achieve for him. And what probably would have been the easiest way, and if we can finish this case in 6 months or so, if not less, is you can take off the upper, run kind of the settling elastics like with a settling retainer as I showed in the last case. If you still need a little bit more class 3 elastics, just run the class 3 elastics again with the upper retainer on. But that would have been, I would say, kind of the easiest and fastest way to finish at this point, because at this point, patient really had no concerns. Actually, he's a friend of a friend. He knew that I was trying to work out the finishing process, so he let me do a digital enhancement. But at this point, actually, he said he was happy. He was ready for things to be taken off. And so in retrospect, what I should have done probably is taken the upper off because I wasn't getting the proper overbite I wanted. And I didn't know at the time, let's just do settling retainers. And then if there was any like lower finishing I wanted to do, so say like that lower right one, I wanted a little bit more finishing on, I could have just done a lower DE and debonded the upper and ran my elastics. That would have been like a way to finish this case, I would say, in 6-7 months. So instead, what I did, I did detailing movements. And as I said, this is a friend of a friend. So he let me kind of try things and try to see how I can get some more movement expression for him. So, I told him, I'm going to add some brackets on the upper 7s just to see if I can get these rotations on these upper 6s to improve a little bit. But, looking at, again, the back, this patient is biting already on the brackets. If I'm extruding the upper and lower 2 to try to get more overbite, it's not going to express because they're just going to bite on the brackets and then it's going to, deactivate or counteract any of that bite closing. So, we bonded the upper 7s. I had to place bite turbos now on the upper 7s due to the occlusal interferences. So again, when you replace upper 7s, you commonly will get occlusal interferences on them. I had to drop back to upper Smartwire, DE Smartwire 1, because I have to stretch to engage those upper 7s. And then we went to lower DE Smartwire 2. So the patient came back a couple weeks later, broken upper right 7, busy schedule. We just sectioned the wire just till the upper right 6. Patient came back actually again a couple weeks later with the upper left 7. So I just decided, actually what we're doing here is just unnecessary to begin with. It was just to kind of try things out for this patient because it's a friend of a friend. And so we just decided to remove the upper sevens, bite turbos, and then we're just going to accept the position. And in retrospect, that's what I normally would do for most patients. So with 5 to 5 or 6 to 6 for 7 to 7, I would say majority of cases can be treated very efficiently with InBrace fitted on upper and lower 6 to 6. If you're only trying to do leveling and aligning on upper lower 3 to 3, then fitting upper and lower 5 to 5 is sufficient. Upper lower 7 to 7 should, I would say, generally be avoided. When you have brackets on the sevens, you get a lot more bond failure just because it's a lot more difficult to isolate. You have also bond failure just because of the occlusal interferences, particularly on the upper sevens. And it's just very difficult to handle the Smartwire that posteriorly as well. So oftentimes it's actually just more predictable if you do want to go to the sevens, just use labial segments from the 6 to 7 or for 5 to 7, where again, patients can't see it when it's that far back. So, in this case, I'm trying to figure out how do I get proper overbite in this case, because the patient is biting on the brackets. So at the time I was like, okay, I'm just going to have him run some vertical elastics. And normally I run it between the IP loop between the upper ones, but on this case I realized, actually, if your incisive papilla is too inflamed, kind of like as shown here, then you can't get anything on this IP loop because it's just too close to the gingiva. So then you have to run it between the upper 1-2 IP loop. This area is almost always accessible, but you have to use a 1/8 inch 2.5 ounce elastic. So it's a very small elastic. Then it's kind of hard to get it on. So you sometimes have to pre-stretch the elastic, and even still, it's a harder elastic to do. So usually I just tell patients, just wear those at nighttime to help with your your vertical correction. And then this patient was still running class 3 elastics. So at the debond check in the next visit for this patient, as I kind of mentioned, we added these rotations onto the upper 5-6 region. When you add those rotations, the mesial and distal out, you're increasing that inner bracket distance. So I would expect a space to form if you didn't add additional virtual power chain as was needed in this case. So at the debond check, when I'm checking for spaces, I do detect, okay, there are some spaces now between the upper 5s and the upper 6s. And the other thing I had noted was there was a vertical discrepancy between the 3 and the 4 that I wanted to improve on. And so again, those spaces here. So, at this point, we're trying to say, okay, what's the best way to resolve these spaces? So I tried 2 different things. On the right side, I was like, why don't we add like a horizontal vector to the elastics to see if that helps close the space. On the left side, I actually ran a power chain on the upper left 5 and 6. And then because I'm trying to actually get, again, more vertical correction, this time I also tried, let's add some bite turbos to get some clearance so that the vertical elastics will work. And then simultaneously, I submitted for digital enhancement. And that way I can deliver the digital enhancement in the next Smartwire. In this digital enhancement wire, I added some additional virtual power chain between the upper right 5-6 and upper left 5-6 to make sure it stayed closed. And then I just added some very minor detailing. So when the patient came back, the spaces were actually still present, even though I ran, again, the power chain on one side and the elastics on the other with the horizontal component. You can still see the space here. So the spaces did improve, I would say, especially on the upper left side where I ran the power chain. However, the power chain actually kind of lightened up the context everywhere. So while this space looks better, it still had a slight open contact and kind of redistributed it between the different teeth. So this is where, again, the DE Smartwire was just the most predictable way to reclose these spaces if you potentially created them with your digital enhancement. And then we're continuing the nighttime elastics. So again, but the catch-22 I would say is that, I know now that I'm going to be biting on these, the patient's biting on these brackets. So, patient comes back the next visit, is ready for debond. I realized, actually I just need to debond the upper. That way the bite can settle. I can run some vertical elastics. So in the next visit, I debonded the upper. I also did a gingivectomy on the upper ones and I performed a frenectomy because the patient started with a diastema. And then I'm running the vertical elastics with that kind of settling retainer. And so I created some cutouts on the upper 2s. You can use like a teardrop plier. And then I'm just running some vertical elastics at night with 1/4 inch, 2.5 ounce elastics. And so when the patient comes back in the next visit, took off the lower, and then we were able to get the overbite. The overbite resolves itself. The bite settles usually within that first month or 2. So again, general nuances of this. When you're in your DE small design in particular, that rotation of that upper 6s, if you don't need to do that, I would say just don't add it in to begin with. So remove any unnecessary rotations that can cause some space opening. If you do need to add it in, just add the additional virtual power chain to make sure you're not going to create those spaces, as would happen in this case. Because again, this case actually I could have probably finished back at the 6-month mark. I mentioned back before DE, before I actually created some of these problems. I could have just ran an active retainer to get the overbite, or a settling retainer to get the overbite I wanted. So again, with the clinical approach, one other thing that I forgot to mention is you have to always keep in mind that your spaces are going to close reciprocally from day 1 in treatment. So again, that upper space is going to close in the beginning. That's why I added the class 3 elastics to begin with to manage the anchorage appropriately, because I want to direct the space closure. When you are debonding the upper arch, when you do need to debond the upper arch first because of the patient's biting on the upper brackets, you can use a settling retainer on the upper to establish your proper overbite, so you can run some vertical elastics once the premature, because you're getting rid of that premature anterior interference. And then again, most cases will start with lower arch. You can start with upper arch in an edge-to-edge situation. Most cases will treat out predictably with 6 to 6. 7 to 7 is more technique sensitive. You can do it, again, just know that it's more technique sensitive. And 5 to 5 is more limited with what it can treat, but it's good if you were just trying to treat upper and lower 3 to 3. Okay, so next case, and for the purposes of time, I'm actually going to skip this case 4. So case 3 and case 4 are pretty similar, but case 3 and case 4 kind of go over again, how do you deal with direct bonding brackets? Again, make sure that you're direct bonding the brackets, kind of what we discussed in the first webinar, and then also make sure you're direct bonding the right bracket. So we have seen people bond a different bracket. So again, lower anterior goes for lower 3 to 3, upper anterior goes for upper 3 to 3. Small and large posterior. Small posterior is generally for premolars, large posterior is generally for molars. We split it like this because small posterior sometimes goes on the upper 7s. So again, just make sure you're using the right bracket, because the locket, each one has a specific locket size, and it won't work. The Smartwire won't be able to engage if you put the wrong bracket on when you're direct bonding. Okay, so we're going to skip through this. And we're going to go to the 4th example. So in my last example, which is, I would just say, a more complicated version of case 3 that we just skipped through, we have a good amount of crowding. And in this crowding, you're going to look through your treatment instructions, and you're going to see which brackets, which teeth are blocked out and which brackets are off-centered. So upper left 2, lower left 1, and lower right 3 are all blocked out. Lower right 3 is severely blocked out. And then you have some off-centered brackets in the upper right 2 and the lower right 1. And so we've gone through, these are your general approaches for creating space for blocked out teeth. So in this case, we fitted both the upper and lower arches. We directional bonded the lower left 1 and the upper left 2. Lower right 3 is 2 blocked out. So actually left it unligated to begin with. The lower right 2 is probably going to come forward, and we perform some lower IPR. And you'll find that we now are creating, again, specialty smart wires that will make this even more predictable to resolve this. So in the first appointment back, I knew I was going to do a lot. So I actually scheduled a little bit extra time, because I know I'm usually within an appointment of the directional bonding, I'll be able to get brackets on. So upper left 2, and then also the off-centered brackets within an appointment, normally you can reposition as well. So the upper left 2 and the lower right 1, which were the off-centered brackets, we were able to reposition them. The brackets that were directional bonded, so that's the upper left 2 and the lower left 1. Those ones we were able to direct bond brackets as well. And then the lower right 3, now we were able to directional bond. And then we perform more lower IP as well. So again, this was a little bit longer appointment because we knew we were going to do a lot of bonding in this case. And then when this patient came back, the upper didn't really need much. So we were able to go to Smartwire 2 because all the brackets are on the planned bracket position. IPR on the upper was performed, and the upper alignment has expressed. While the lower is more the rate limiting step in this case. So this is the case where maybe you would have started with the lower to begin with, because the lower is going to take longer. And so the lower rate 3, we were able to get a bracket on. It was direct bonded in an offset position. And so all the other bracket positions were checked, so they're good. We're still performing. We finished the prescribed lower IPR, and this lower right 3 essentially becomes your rate limiting step. So a lot of times my assistants will struggle to get the bracket engaged. And so anytime they struggle to get the bracket engaged, the first thing I just tell them is go get some free spray, and that'll soften things up. And so when you do have a case like this where you have to put a bracket into a very tight, crowded situation, I would say the first thing you should do is when you're doing your direct bonding, leave just a small, like a slight amount of space, because you want to leave a little bit of space so that an IP loop can fit in that space essentially. And then the second thing is you're going to want to use free spray to make the wire dead soft, because then you'll be able to kind of manipulate the lock in an IP loop however it needs to go to kind of get it into this very small, tight, crowded situation. And then the third thing you should do is you should engage the crowded bracket, the bracket in the crowded situation first. So in this case, again, you would engage the canine first. This is pretty similar, I would say, to traditional braces as well. Normally, you'll engage your really rotated tooth first because you have more flexibility. The other reason is if you engage, say, this lateral first, then the IP loop, the shoulder it would be on the inside, more in this contact area. But you actually need this IP loop, this portion of the IP loop, to be more labial, so to kind of be in this space. If you do it the other way, again, this would be blocked and you won't be able to get engaged. Okay, so then the next visit, lower right 3 was able to reposition again. I made a note in the chart. I placed it in an offset position. And then we're going to reposition it again via direct bonding. And so at this point, when I'm looking at my case, I'm saying, okay, all the brackets are in the right spot. They're near their planned bracket position. All the IPR has been performed and my leveling and aligning is complete. So I can go to upper and lower Smartwire 2. So we checked that the lower right 3 bracket in the next visit at 8 months. We checked the bracket position. Looks pretty good. Alignment looks pretty good. So we engaged the lower Smartwire 2. And essentially within a visit, we letting the wire express. The bite is not that far off. So I decided, we're probably just going to need to run some settling elastics at the end. And then we didn't have any bite turbos at this point. And I also know, again, I have a lot of direct bonded brackets in this case. So I don't need to let this wire keep going and going because I need to go to digital enhancement to kind of address any bracket position errors that I did with range direct bonding. Because again, as long as they're close, we can address it with digital enhancement. So with digital enhancement, with the final detailing, again, less is more. I didn't add too many movements in. Actually, the other thing I wanted to add in was things were a little bit still too flared. So I added a little bit more IPR on the upper and lower so I can close those IPR spaces. And we delivered the upper and lower DE Smartwire 2s. We performed the upper and lower IPR. And essentially when this patient came back within one visit for the debond check, patient was happy, had no remaining concerns. I wanted to get a little bit more overbite and I wanted to improve the lower alignment very slightly. Could have very easily done this with active retainers, but I decided, again, the upper patient's biting on the upper brackets. So I'm just going to debond the upper first. I'm going to let the patient settle for a month or two with the upper off. So I can also submit for a digital enhancement on just the lower arch and just do any of the final minor detailing that I wanted to do. So again, just very minor detailing on the lower 2-2, lower 3-3. So I engaged the the lower DE Smartwire 2 just for my final lower detailing. Again, that could have easily been done with an active retainer instead. But I put that lower wire in, I debonded the upper arch, performed a little bit of enamelplasty and gingivectomy, and then I started again the same kind of settling retainer to run my anterior vertical elastic just at nighttime. And so then when the patient came back in the next visit, we took off the lower, and then I was able to get the proper overbite that I wanted in this case. And then that finishes up this case here. So the key nuances of this case were, again, just the less is more with the detailing, only moving the teeth that you wanted to be moved. You sometimes have to reposition a bracket multiple times when you're dealing with severely rotated teeth. And again, minor inaccuracies in the bracket position are acceptable. Any major inaccuracies should be repositioned again. But the minor inaccuracies we're able to resolve with digital enhancement. And then with clinical technique, when you're engaging, again, a direct bond in a very tight, crowded situation, use the free spray and engage the bracket, engage this particular bracket before its adjacent brackets. So that completes mastering the nuances of InBrace. Again, we just went over straightforward cases, but we're going to build on this in the future webinars in the coming months, and we're going to go over to more and more advanced cases. But we're just trying to create the foundation here. We are going to have a study club this month. Again, study clubs, we're launching peer-to-peer study clubs that'll be hosted by fellow providers. We're going to go through cases that go over kind of the topics that we went over in this month's webinar. And then you'll have the opportunity to also review your own cases. So we do recommend to reach out to your TIS or regional sales director if you are interested in being involved in these study clubs, because they're by invite only.